This is The Rounds Table. Welcome back, listeners. This is a solo episode, and I will be discussing the recently published randomized trial entitled Deferring Arterial Catheterization in Critically Ill Patients with Shock, the EVERDAC trial, published in New England in November of 2025. So, those radial art lines, they are such commonplace in the ICU. It's recommended for patients with shock, but it's based on no randomized trials. I am, of course, not an intensivist, but I remember my days in the ICU as a first, second, and third year resident. And yep, very, very common for patients to have an arterial line put in place. And I'm pretty sure times haven't changed all that much, and it's probably the same. The use for them and their potential benefit is clear and appealing. You have beat-to-beat variability in heart rate and blood pressure, and you can, quickly titrate medications. It also gives very easy access for patients who need, frequent blood draws. The risks, on the other hand, a risk of a hematoma, infection, pseudoaneurysm. So, it begs the question, is sort of non-invasive blood pressure management, good old-fashioned blood pressure cuff, is it not worse than arterial line? And this is what set up the early versus deferred arterial catheterization in critically ill patients with acute circulatory failure, the EVERDAC trial. And it was designed to evaluate whether management of shock without early arterial catheterization was non-inferior to just the good old-fashioned blood pressure cuff. So let's jump into the methods here. It was an open-label, pragmatic, as mentioned, non-inferiority trial, academically funded. The population included adults age 18 and up, admitted to the ICU in the last 24 hours. They had to have persistent hypotension. Often that was defined as a blood pressure below 90 systolic for at least 15 minutes, or a low enough blood pressure that vasopressors were initiated, and there had to be one sign of tissue hypoperfusion. The exclusion criteria were pretty minimal. Patients who are on ECMO, patients who are on a high dose of pressors, they defined it as more than 2.5 micrograms per kilogram of body weight for example, norepinephrine. BMI above 40 was another exclusion. And for patients who were pregnant, I'm not sure why that was an exclusion criteria, but that's what it was. The intervention was non-invasive strategy group. They refer to this as like no early arterial catheterization. And in this group, insertion of an art line was not permitted after randomization, unless, of course, there was some safety criteria that came up. The safety criteria that they used in this study included, inability of the bedside monitor to display a value for pulse oximetry or non-invasive blood pressure. So if it was just so low that the blood pressure cuff just couldn't be picking it up. If there was a need for arterial blood gas measurements after 5 consecutive failed arterial puncture attempts. So, somebody tried to do an ABG a bunch of times. They made it to time 5. They still couldn't get it. Okay, fine. Then we'll allow you to put in an art line. If the patient subsequently needed ECMO, then go ahead, put an art line in. Or if there was a very high dose of vasopressors that were needed. So those were the sort of safety criteria where even in this non-invasive group, you could put an art line in. The comparator was referred to as invasive strategy group, and this was early arterial catheterization. So this was putting in, the radial art line within 4 hours after randomization. And in some cases, the patient might have already had one in place, so they just kept it in there. The primary outcome was pretty clean. It was death from any cause at 28 days after randomization. Kind of interesting, this trial was run in France, and in terms of consent, they note the following: in accordance with French law, which classifies research such as this trial as involving minimal risk and constraints, patients or their legally authorized representatives received an information sheet and provided documented explicit oral consent. That's very pragmatic, right? I read that and think like a 1-page summary of what's going on, and verbal consent is all you need. Certainly in North America, that isn't standard, and usually it's like a 20-page consent form and often written consent, but I'll leave it at that for now. The statistics bear with me for just 1 minute here. So how did they power the study? They hypothesized that the risk of death by 28 days would be 25% in the invasive strategy group and a little bit lower, 22.5% in the non-invasive strategy group. This was based on some prior non-randomized data. And they calculated a sample size of just over 1,000 patients to give 80% power. And with these non-inferiority trials, the question is, well, what was your margin? And the bigger the margin, the smaller your trial can be. And in this case, they had a non-inferiority margin of 5 percentage points. And we should ask ourselves, like, if you're an intensivist or an internist who puts in art lines, do you buy that 5 percentage points is an acceptable non-inferiority margin when your primary outcome is death, or would you want something smaller? I'll leave it at that. Moving on to the results. So they assessed just over 4,000 patients for eligibility between 2018 and 2022, and a total of 1,010 were randomized. Average age was 66, 35% were female, 94% were in a medical ICU. The remaining 6 some odd percent was a surgical ICU. 55% of the patients had septic shock, 12% had cardiogenic shock, 10% had post-cardiac arrest shock, and the remaining, mental math is hard, the remaining 20% was other, as well as, a very few percent had like obstructive shock. Also note that 90% of patients were on pressors. In terms of their past medical history, we don't have a ton of details, but here's a few points. 27% had diabetes, 7% had cancer, 7% had a prior MI. So I also want to note that in the non-invasive strategy group, some of them, and to be more specific, 64 patients or 13% already had an art line put in prior to randomization. Of those 64, half of them had them removed within an hour after randomization, and the other half had it removed generally within 24 hours after randomization. In the non-invasive strategy group, I'll also note that 74 patients underwent arterial line catheterization. So, we refer to that as crossover. They got randomized to just use a blood pressure cuff, but 15% of them ended up getting an art line. And most often that was because they met one of the pre-specified safety criteria that I mentioned. And then 98% underwent arterial catheterization, insertion at a median of 1 hour after randomization. I should make that more clear. In the invasive group, 98%, had one inserted within an hour after randomization. Okay, so, let's get to the point here. The primary outcome of death at 28 days, what did they find? So that occurred in 34% in the non-invasive group and 37% in the invasive arm. So that's actually 3 percentage points higher in the art line group, and the exact risk difference was 3.2 percentage points, confidence intervals going from a negative 8.9 to 2.5. So that upper bound does not include the non-inferiority margin of 5%. Hence, we would call this non-inferior. Good old-fashioned blood pressure cuff was a non-inferior to an art line. And if anything, that point estimate suggests maybe there's a hint of better outcomes if you just had the good old-fashioned blood pressure cuff. A few secondary outcomes which are worth mentioning. 5 patients, or 1% in the non-invasive group, developed a hematoma or hemorrhage, compared to 41 patients, or 8% in the arterial line group. So much higher risk of a hematoma or hemorrhage if you had an arterial line inserted. They also looked at the incidence of art line related bloodstream infections. There was 1 in the non-invasive group and 3 in the invasive strategy group. So that had an incidence ratio of 0.18, with confidence intervals going from 0.06 to 0.54. Said differently, the rate of bloodstream infections was lower in the blood pressure cuff group compared to the art line group. There's many other secondary outcomes. I'm not going to go through all of them. One thing that I was sort of wondering about is how about the risk of blood transfusion? Maybe in the art line group, they would be more likely to need a transfusion because you're doing so much more blood work. But in this case, they actually found almost identical risk of transfusion between the two arms. A few limitations. So first, this trial was, of course, unblinded, which could potentially introduce bias. However, I don't see that introducing bias in the primary outcome of dead at 28 days, because dead or alive, if you're blinded or you're not, I think you're going to call it the exact same. Another limitation here is that most of the patients were admitted to a medical ICU, so who knows how well this applies to a surgical ICU, but I really don't expect art lines to be of a major value add in that patient population. Like, that's not where my priors are, at least. And they also commented that very few of the patients were trauma, and of course they excluded adults with a BMI above 40, so results don't apply to that group, to name just one. So there you have it. That is the EverDAC trial. And to me, it makes me think that, all those arterial lines, are they really needed? This randomized trial suggests no, that they are probably unnecessary for the vast majority of patients in the ICU. Is there still a subset of patients who would benefit from it? Of course. Imagine the patient on ECMO. Of course, they need an arterial line. Imagine the patient who's on multiple different pressors at really high doses. I get it. There might be a place for an art line there. But more generally, for the sort of typical patient with shock who's admitted to the ICU, the results of this trial suggest it's probably not needed. Well, that's it for today's episode. I would love to hear feedback from intensivists or anyone who spends some time in the ICU. Let me know what I got wrong here. Speaking of the ICU, we've just launched Critical Care Trial Files. It's being led by Chad Beck. He's a senior resident here in Toronto and a future intensivist. At least I think that's what he wants to do. So we'll include a link to that in the show notes if you want to sign up. It's a monthly newsletter drafted by a large language model, and we'll keep you up to date in all things ICU randomized trials. That's it. Stay well and have a nice day.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.